volumes and capacities. Lung volumes and capacities are measured by spirometer. These are important lung function tests. Here you can see these are the various diagrams of spirometer. Now, these lung volumes and capacities are divided in two types: static lung volumes and capacities and dynamic lung volumes and capacities. Static lung volumes and capacities are those in which time factor is not involved, so they are expressed in milliliter or liter. Whereas in dynamic lung volumes and capacities are time dependent and therefore they are expressed in milliliter per minute or liter per minute. Starting with static lung volumes and capacities. First one is tidal volume. It is the volume of air inspired or expired with each breath during normal quiet breathing. It is approximately 500 ml in normal adult male. It decreases due to loss of contraction of respiratory muscles, respiratory muscle weakness, depression of respiratory centers, and it increases during muscle exercise. Inspiratory reserve volume. It is the extra volume of air which can be inhaled with a maximum inspiratory efforts beyond the normal tidal volume. And the normal value is about 3000 ml, ranges 2000 to 3200 ml in normal adult male. Third one is expiratory reserve volume. It is the extra volume of air which can be expired by maximum forceful expiration. Normal value is approximately 1100 ml and ranges 750 to 1200 ml in a normal adult male. Residual volume. It is the volume of air that remains in the lungs after most forceful expiration, and the volume is about 1200 ml in normal adult male. Respiratory volume can be calculated from functional residual capacity. Another is closing volume. It refers to the lung volume which coincide with the beginning of airway closures, and this is in the dependent parts of the lung during expiration, and because of less transmural pressure in these areas, the closing volume of lung can be measured. In normal healthy individual, it is always less than functional residual capacity and more than residual volume. Lung capacities. These are the combination of one or more pulmonary volumes. Inspiratory capacity. It is the maximum volume of air a person can inspire after completing tidal expiration. Tidal expiration means beginning at the normal and expiratory level, and it is equal to tidal volume plus inspiratory reserve volume. The value is approximately 3500 ml in normal adult male. Expiratory capacity. It is the maximum volume of air that can be expired after completing normal tidal inspiration, and it is equal to tidal volume plus expiratory reserve volume, and the value is about 1600 ml in a normal adult male. Next capacity is functional residual capacity. It is the volume of air remains in the lungs after normal tidal expiration. It is equal to expiratory reserve volume plus residual volume, and that is about 2300 ml in a normal adult male. FRC, functional residual capacity, is measured by two methods, and they are: first is open circuit method or nitrogen washout method, and second, that is closed circuit method or helium dilution method. Starting with first, open circuit method or nitrogen washout method. It is based on the assumption that alveolar air has 80% nitrogen, and ask the subject to inspire pure oxygen for 5 to 7 minutes and expires in a spirometer or expires in a Douglas bag. which is washed with pure oxygen and therefore it is nitrogen free. Volume of gas collected in the Douglas bag and the nitrogen content are measured and FRC can be calculated. Calculation: about 40 liters of gas is expired in 5 to 7 minutes and 5% is nitrogen. So you can say that 100 ml of air contains 5 ml of nitrogen. Therefore, 40,000 ml of air contains how much nitrogen? That is equal to 40,000 multiplied by 5 divided by 100 is equal to 2,000 ml nitrogen. Now, as we all know that about 80% of nitrogen is present in gas mixture. Means 80 ml nitrogen is present in 100 ml of air. Therefore, 2000 ml of nitrogen is present in how much air? That is equal to 100 multiplied by 2000 divided by 80. And therefore, FRC is 2500 ml. Closed circuit method or helium dilution method. Here, spirometer of known volume is filled with the air and it is mixed with the known concentration of helium. And as this is closed circuit method, ask the subject to inspire as well as expire from the spirometer. So person has to inspire and expire from the spirometer for about 8 to 10 minutes, because up to this 8 to 10 minutes equilibrium is achieved, means all the FRC volume has come out. The calculation is V1C1 is equal to V2C2. V1 is initial volume of spirometer, C1 is initial concentration of helium, V2 is final volume of spirometer, C2 is final concentration of helium. So V1C1 is equal to V2C2, in which we can replace the V2 by V1 plus FRC, and by mathematical calculation we can calculate FRC. Significance of FRC. FRC has various advantages. First and foremost is gas exchange becomes continuous because of presence of some amount of air in the lungs. Second is breath holding is possible due to FRC volume. Third advantage is toxic gases can be diluted because we have a reserve of about 2300 ml of air in the lungs. And fourth one, it prevents collapse of lung. Factors affecting FRC and RV. In certain conditions, FRC and RV increases because of hyperinflation of lungs, like in old age because of loss of elasticity of lung, in emphysema and in bronchial asthma. Next capacity is vital capacity. It is the maximum amount of air a person can expire from the lungs after deepest possible inspiration. It is equal to tidal volume plus inspiratory reserve volume plus expiratory reserve volume, and the value is about 4600 ml. Factors affecting vital capacity. Physiological factors are size of the thoracic cavity. Vital capacity is always more in males because of the large chest size. Vital capacity of male is 2.6 liters per meter square of body surface area, and in females it is 2.1 liter per meter square of body surface area. All the volumes and capacities are 20 to 25% more in males. Because of the large chest size, more muscle power and more body surface area. Second factor is age. Vital capacity decreases with increase in age due to decreased elasticity of the lung, and aging replaces elastic fibers by fibrous tissue. Third physiological factor is strength of respiratory muscles. In swimmers and divers, vital capacity is more because of increased strength of respiratory muscles. Factor is posture. Vital capacity is more in the standing position than in lying down position, because in standing position diaphragm descends down, which increases the size of thoracic cavity in standing position. Also, there is decrease in the venous return, and therefore pulmonary blood flow also decreases. Physiological other factor is pregnancy. Vital capacity is reduced due to pushing up of the diaphragm and reduced capacity of thoracic cavity. Pathological factors are ascites, that is accumulation of fluid in the abdominal cavity. Vital capacity is reduced due to the same reason as in pregnancy. Pulmonary diseases like pulmonary fibrosis, emphysema, respiratory obstruction, pulmonary edema, pleural effusion, and pneumothorax. These are the other causes for decrease in vital capacity. Next is total lung capacity. It is the maximum volume of air present in the lungs after maximum inspiration. It is equal to vital capacity plus residual volume, and the value is about 5800 ml in male. Next is dynamic lung volumes and capacities. Here time factor is involved, so it is measured in milliliter or liter per minute. Timed vital capacity, or other name for that is forced vital capacity. It is the volume of air that can be expired forcefully and rapidly with a maximum force after maximum inspiration. The volume of air expired can be timed by recording the vital capacity on a spirograph, which is moving at a known speed. And the components of FVC, they are FEV1, FEV2 and FEV3. FEV1, it is the percentage of FVC expired in 1 second, and that is 80% of FVC. FEV2 is the percentage of FVC expired in first 2 seconds, which is about 90 to maximum 95%. FEV3, it is the percentage of FVC expired in first 3 seconds, and it is about 98 to 100% of FVC. Clinical application of this timed vital capacity. Estimation of forced expiratory volume in per second is the most commonly used screening test for airway diseases. FEV1 percentage is equal to FEV1 divided by FVC multiplied by 100, that is 80% normally. It is useful in distinguishing between restrictive and obstructive lung diseases. Patients with restrictive lung diseases like emphysema, kyphoscoliosis, ankylosing spondylitis, they have decreased FVC, forced vital capacity, but able to achieve high flow rate, means FEV1 percentage is normal or sometimes more than normal. Whereas patients with obstructive lung diseases like bronchial asthma, they have high airway resistance and low flow rate. Therefore, FEV1 percentage is abnormally low. This FEV1 is reproducible and highly sensitive index of obstructive lung disease. This is algorithm for diagnosis. You can say that FVC, if it is more than 80% and FEV1 is also more than 80%, you can say the person is having normal lung function. But if FVC is more than 80% but FEV1 is less than 80%, the pattern is obstructive lung diseases. And second is FVC when it is less than 80% and FEV1 that is more than 80%, the pattern is restrictive disease. Whereas both FEV1 and FVC both are reduced, then you can say that combined obstructive as well as restrictive lung disease. FEV1 is reproducible and it is highly sensitive index for obstructive lung diseases. However, it does not differentiate the different causes of obstructive lung diseases. Next parameter is forced expiratory flow during 25 to 75% of expiration. It is also known as maximum mid-expiratory flow. The normal value of it is 300 liters per minute and the time, mid-expiratory time is 0.5 second. It is the sensitive indicator of small airway diseases. Another parameter is FEF 200 to 1200 means forced expiratory flow during 200 to 1200 ml of expiration. You can see in the diagram. This is the FEF 200 to 1200 ml. It refers to mean expiratory flow rate between 200 to 1200 ml segment of FVC, and the normal value is 350 to 400 liters per minute. But the disadvantage of measuring FEF 200 to 1200 is in the initial phase of FVC, the fall is very rapid and the pressure difference is too much. So we may miss small airway obstruction. Another parameter is peak expiratory flow rate, that is expiratory flow rate during the peak of FVC, and the normal value is 400 to 450 liters per minute, and it is measured by peak flow meter that is depicted here, and this flow is reduced in obstructive lung diseases. Next is respiratory minute volume, also known as minute volume or pulmonary ventilation. It is the volume of air inspired or expired per minute. It is equal to tidal volume multiplied by respiratory rate. Can calculate it. 500 multiplied by 12 is equal to 6000 ml per minute. Maximum voluntary ventilation, other name is maximum breathing capacity. It is the maximum volume of air that can be ventilated on command during a given interval. The index of ventilatory function depends upon the cooperation of the subject, who is asked to breathe as rapidly and as deeply that he or she can, and this is to be performed for only 15 seconds. The volume of the air which is expired, that is collected in the Douglas bag, and this is expressed in liter per minute. Normal value is about 90 to 170 liters per minute. Maximum voluntary ventilation depends on muscular force available, compliance or distensibility of thoracic wall and lung, and airway resistance. Therefore, it is reduced in patients with emphysema, airway obstruction, and very poor respiratory muscle strength. Important note, here we describe that person is allowed to hyperventilate for 15 seconds. Why? Because hyperventilation causes carbon dioxide to wash out, and which leads to respiratory depression. This may result in fainting attack. Therefore, voluntary hyperventilation should be done for only 15 seconds. Next parameter is breathing reserve, also known as pulmonary reserve. It is the maximum amount of air above the pulmonary ventilation that can be inspired or expired in 1 minute. It is calculated by maximum voluntary ventilation minus pulmonary ventilation or respiratory minute volume. Maximum voluntary ventilation, suppose it is 100 liters and the pulmonary ventilation is 6 liters. So breathing reserve would be 94 liters per minute. Another parameter is dyspnea index. Pulmonary reserve is expressed as percentage of maximum voluntary ventilation or percentage of pulmonary reserve, or it is also known as dyspnea index. Therefore, dyspnea index is equal to maximum voluntary ventilation minus pulmonary ventilation, or you can say breathing reserve divided by maximum voluntary ventilation multiplied by 100. Normal values of dyspnea index or pulmonary reserve percentage ranges from 60 to 90% or average is 75%. Dyspnea is usually present when this value is less than 60%. Thank you. Thanks for watching. These are the short notes. May be asked. You can write down all these short notes. These are the short notes frequently asked from the today's topic. Now let us come to MCQs. Functional residual capacity is volume remaining after forceful expiration, tidal volume plus volume inspired forcefully, volume remaining after normal expiration, and tidal volume plus volume expired by forceful expiration. We all know volume remaining after forceful expiration, that is residual volume. Okay, tidal volume plus volume expired forcefully, that is your inspiratory capacity. Okay, so this one is the answer after normal expiration. Okay, total lung capacity depends on size of airways, closing volume, lung compliance, and residual volume. Size of airways, because it includes dead space also, so it is not. Closing volume, that is less than residual volume, so not concerned with the total lung capacity. Lung compliance, that is distensibility. More the distensibility, more is the amount of air remains in the lungs. Compliance. Residual volume is the air remains after forceful expiration. So this is also not total lung capacity. So your answer would be lung compliance. If lungs are more distensible, more capacity is inside. Respiratory minute volume of lung is, we all know, respiratory minute volume is equal to, if anyone can remember what is respiratory minute volume, is, or it is also known as pulmonary ventilation. So it is equal to tidal volume multiplied by respiratory rate. Normal tidal volume, that is about normal tidal volume, that is 500 ml multiplied by respiratory rate, if it is 12, this would be about 6 liters per minute. So this is your respiratory minute volume. Okay. Inspiratory capacity. Sorry. This. Inspiratory capacity is residual volume plus IRV. Here if it is residual volume plus IRV, there is no capacity. IRV plus tidal volume. Tidal volume is 500, IRV is 3000. So this is equal to IC. Okay. IRV plus ERV, no capacity, is like IRV plus ERV. ERV plus RV is equal to FRC, functional residual capacity. Okay. So correct answer is B. Vital capacity provides useful information about size and development of chest wall, strength of respiratory muscle, patency of respiratory passage, pulmonary ventilation. Vital capacity is more in males, in divers. Why? Because their strength of the respiratory muscle is more. So your answer is strength. Okay. Size and development, not the development. Patency, not the patency. And pulmonary ventilation also, it is not concerned. Which of the following is not correct? Tidal volume 500, correct. IRV 3000 ml. Vital capacity is equal to IRV plus tidal volume plus ERV. Okay. So is equal to 500 by tidal volume 3000, IRV and ERV is 1100. So is equal to 4600 ml. Okay. So this is your vital capacity. Okay. This is not correct. Then FRC is measured by we have discussed. FRC cannot be measured by spirometer because it is remaining inside the lung. Fowler's method is used to measure dead space. Bohr's method is used to measure physiological dead space. And nitrogen washout method or open circuit method is used to measure FRC. FeV1 upon FVC is reduced in. Okay, so that also we have discussed in the dynamic lung volumes and capacity. Here, FeV1 means in first second. If the person is having obstruction, then in first second, expired air is less. So, this is in asthma. Okay. In fibrosis and scoliosis, restrictive diseases. So, the person is having reduced FVC, not FeV1. Okay. Then, false about obstructive lung disease. Maximum mid-expiratory flow rate reduced definitely because obstruction, flow rate decreases. Because of obstruction, air remains inside the lung, so residual volume increases. Diffusion capacity has no role. Okay? There is obstruction, but diffusion is there. And FeV1 is reduced, not normal, so this is not correct. Okay? Dyspneic index is, we have discussed, maximum voluntary ventilation minus respiratory minute volume or pulmonary ventilation multiplied by 100 divided by maximum voluntary ventilation. So this would be the answer. Here, this is plus. So this is the answer. So here, this is all about MCQs. Thank you all. अगेन नए बच्चों के लिए मेरे सभी नोट्स आपको वैसे इस एप्लीकेशन में मिल जाएंगे, साथ साथ में मेरी बुक फिजियोलॉजी नोट्स दोनों के लिंक्स डिस्क्रिप्शन बॉक्स में दिए हुए हैं. थैंक यू सो मच.